The next one will be posterior ankle impingement, usually commonly seen in the ballet dancer and the patient who play soccer and like to kick the ball from the back of the ankle. So the history of the patient usually presented with the posterior ankle pain, which is the opposite of the anterior ankle impingement. And the patient also usually have the limited plantar flexion because when you perform the fully plantar flexion, the bone on the back can be impinged on the distal part of the tibial plafon, and also the calcaneus, we so-called nut cracker. On physical examination, if the patient have the flexor hallucis longus tenosynovitis due to long standing of the osteophyte is irritated on the FHL tendon and cause hypertrophy. And when this tendon run along the groove, it can be hitting or irritation on the bone spur and then cause a squeaking sound. Patients usually have pain when we palpate on the back of the ankle, and also the posterior ankle impingement test is just positive when we perform suddenly fully plantar flexion. The patient have pain on the back of the ankle. So the imaging that's commonly used to identify the posterior ankle impingement, you usually use a lateral view of the ankle, similar to the anterior ankle impingement. You can see that the bone right here we call the osteochondral. If this bone filled to the talus, we call posterolateral process or stator process. CT scan can be helpful too. You can see it clearly from the 3D imaging CT scan. MRI sometimes can be helpful if you are thinking about the stress fracture or bone marrow edema, also the bone bruise and have injury on the back part of the osteochondral. For treatment, we can start with conservative management by using like rest, activity modifications, and also the anti-inflammatory medication or NSAID. And sometimes steroid injection also helpful to decrease the inflammation. However, if this fails, surgical treatment is indicated. We can perform either open arthroscopy to remove the osteochondral strata process, or either non-union of the fracture. And the last one is osteochondral lesion of the talus is usually common follow the ankle sprain or ankle fracture, and the patient have persistent pain and swelling. So you can see the patient have the chronic pain and swelling of the ankle sprain more than 6 to 12 weeks. So you need to be consider this problem because it can occur up to 50% associated with rotational ankle injury. On physical examination, patients usually have pain on the anteromedial or anterolateral parts of the ankle. Patients usually come back and complain about the swelling when they do long running, long walking. So imaging can be helpful. So X-ray they have low sensitivity, it's approximately 20%. But if a negative X-ray cannot be ruled out these conditions, so MRI is a gold standard to identify this problem. If you perform an MRI, you can see the bony defects right here and right there. Okay, and then this is a bony fragment you can see on the top of the talus. So the treatment usually performed if the lesion was small, less than 15 millimeter, you can perform arthroscopic treatment and microfracture. But if the lesion is big, you need to do other procedure such as the autograft or allograft, or you can use some kind of total talar prosthesis if the lesion is too much involve more than 50% of the talus. So here's an example of the treatment. So you can see here, this is the top line, two line. This is we call debridement and microfracture. We can use a sharp instrument we call an or conduct pricks to make a hole. And this is the bleeding. So when the blood coming out, they have a potential stem cell that can be differentiated into the cartilage. And on the middle part, you can see here, this is we perform medial malleolar osteotomy, and then we open the medial side up, and then we can see the cartilage damage here. And then we can reaming, and then we harvest the allograft this is from the total talar allograft, and then we put it on, and like snowman on the right bottom picture. And here this is commonly new. This is a new technique that we use the cartilage from the kids that die before age of 6 years old. We call juvenile cartilage. This is a de novo. So we put it on after we perform arthroscopic debridement and microfractures, and then we put the cartilage on top of the defects, and then put the glue to secure the cartilage into the bed of the defects.